masses are pretty ill-defined on how it looks. So
Right.
I think the radiologists when they do the measurements, they try to say, well, that looks like the irregular borders, but there's some surrounding haziness. And so
Mm.
when he went back and looked at all the other images, he thinks that that's how it was measured previously.
Okay.
So he's saying it looks about the same for the mass itself,
Mm.
but with obviously irregular borders, all those things.
Mm.
Then I also asked him about the vessels itself, and so there looks like there is some no major change in the vessels. He's saying
Mm.
there seems to be a little bit of fat plane between the vessel and the area of the mass for the artery, what we call the SMA. And then the SMV has abutment of the vessel of the mass there, just like previously, but it's not a significant amount. Okay, so it's about 90 degrees or so of that. So I think this helps the surgeon make those determinations. Of course, the surgeon's going to look himself for these things, but these were a little bit of things that were omitted on the report. I wanted to go back and add on there. Okay, so that we have some better clarity about, well, are we a good candidacy of surgery or not? Okay, so I think this will help. Dr. Kabaturu make that determination, and I'm happy to work with him if he thinks some radiation would be helpful. I'll talk to my colleagues here. If we want to continue systemic therapy, that's fine. I wouldn't say there's a drastic change, but I'd say it's a positive in the sense that nothing else has grown. Right? That's always a good positive thing as
So
well.
it hasn't reduced 30 to 40%.
No, I don't think so, based on what the radiologist is saying. So, despite the numbers on the reports being that way, what I was describing is that surrounding haziness and who measures what and how it gets measured is the big question. So, that's the things I want to get clarified.
Yeah.
So, okay. So,
Okay.
I still think it's a positive. I still think patients that don't get progressive disease are still candidacy for surgery, like you are in this situation, because the vessel involvement is minimal. Should get that opinion. I know you met the surgeon in Grand Rapids, right? And then the one locally here. So, let's see how that goes. Now, you were talking about your treatment on Monday.
Right.
What time is your appointment at the eye clinic?
At 10.
The eye clinic is 10 o'clock? So, I mean, I don't think it's a big deal.
That's fine.
You could come back here and get disconnected afterwards, right?
Yeah.
Just see how you feel. And
Yeah.
I think it's important to kind of go to that appointment if you can.
Okay.
Okay?
Okay.
All right. Yeah. Anything else you discussed with Dr. Christie that you need clarified, or?
No.
Okay. We'll continue the same dosing for now. I wouldn't change that right now.
So is it normal though that, I mean, the differences between the size of the tumor and the haziness, is that a normal thing to, because that report scared us that night big time, that like it's not changed the size.
Right, and it hasn't.
So now you're saying it hasn't changed much in size?
Yeah, so when you look at the images, you can tell there's not a discrete border for the mass, right?
Right.
And that makes it tough for anyone reading it then. You have irregular borders, and on top of that, you have changes going around the mass itself. And so to get exact measurement is it's difficult, right? And so that's why I go back to the radiologist.
It's just like an estimation.
Basically. It's an estimation, right? But it's where you're putting your marker, right? You're starting here or you're starting here.
Right.
And that's why I wanted him to go back and have his opinion. I like him. He does a lot of the stomach cancers and stuff like that. So he says I don't think overall it's changed much in the haziness or the mass effect itself. And then I asked him about the vessels as well. So I think it's radiologists are reading what they're seeing, and we're relying on their perspective of where they put the measuring tape, basically, right?
Right.
So, but ultimately, it comes to the surgeon, right? And so Dr. Kavaturu is great. He'll review the images and he'll go from there. Do you guys need to get the disc for him? Is that something he's told you about or anything like that? Because he won't have the disc necessarily. You may want to call their office and see.
Okay.
Okay.
All right.
Because he works, perhaps. I don't know if he has access to the disc here.
Yeah, so. I can't remember last time if he had that or not. But.
Yeah. Okay.
Okay.
Just so you can have a fruitful conversation.
Because I was talking to Dr. Christie about this a little bit, because what's the process of a second opinion? And what good, I mean, because we talked about sending some information down to Cleveland or whatever.
Sure. Yeah. It's quite easy. I mean, you just decide where you want to go. You always get your first opinion, in my opinion, right? You get your first opinion. Then you can get a second opinion. I think the hardest thing sometimes is the timing of an appointment.
Yeah.
So if you get on the book somewhere, that helps you. And then gathering the discs, of course, are helpful. Our notes are easy to gather, right? Nowadays, the EMR is at your disposal, right? So If you wanted a second opinion for a surgical opinion, medical opinion, whatever it is, I think you can easily do that. Some places are set up to have like a multidisciplinary approach where you may meet all the players at one time. I just don't know how everybody's set up for that. But that's always an option that you have, and I think it's, to answer your question, it's quite easy. The difficulty is getting into the office, right? So some places like we try our best to get patients in cancer right away.
Right.
But gosh, if you ask my next available, it's not for a while.
Exactly.
So
Yeah.
getting the book somewhere is helpful.
Yeah.
So,
Alright.
but get your first opinion from the
yeah.
surgeon here. You also have your second opinion, perhaps from the surgeon at Grand Rapids.
Yeah.
So they both seem, and I know Cavature, and I assume the other surgeon is well equipped to do these
Oh my
surgeries all
gosh,
the
yeah.
time.
Oh, he had a bio that was this long. He
Yeah,
was
yeah,
incredible.
exactly. So I think you got great surgeons locally from that perspective.
Well, that's I guess the, what else was I? I'm drawing a blank now all of a sudden.
Yeah, so do you think this is normal that the mass hasn't shrunk with as much chemo? I mean, I know I've only had 6 sessions of chemo. And
Well, I think personally, yes. I think, unfortunately, pancreatic cancer is one of those tough cancers.
Yeah.
If you look at the literature, getting a response is tough. We do our best up front because I think there's a benefit to those patients that do get that response, right? And then, we try, and we're trying to figure that out, augmenting with radiation or not. Is that helpful to downsize before surgery? These are all things that we're trying to figure out for this kind of cancer. It used to be a point where surgery was recommended up front for everybody. Now I think we're saying, well, perhaps some neoadjuvant chemotherapy is helpful for many cases, maybe even all, right? I think that you've got varying opinions out there for that. So, like many other types of cancer, we're trying to figure out what the right approach is, what the right sequence is.
Yeah.
Obviously, chemo is in your future. At some point, we try to put that up front to see if there is that ability to get downsizing, or maybe a sandwich approach or something, right? So we're trying to figure those things out.
Well, what benefit is it going to be? Because we discussed this with Dr. Christie, because we went to half dose because she didn't have her pain under control and she was in the hospital for 8 days. What benefit would it be to even go 3/4 as compared to half? And we just decided that it was going to be half the Monday.
I don't think that few milligrams is making a difference.
It's just a small amount.
I think getting the drug in is important, but also tolerating the drugs is more important, right? Because if we're causing delays or you're not staying on sequence, I think that's a big problem. So let's get the opinion of surgery first. If we're not going to do surgery, we can totally talk about that, right? Going and adjusting the doses as necessary. But my concern is getting you to tolerate things, right? We have those early problems going on here.
But she hasn't had that in the last.
Absolutely not, right? So, but sometimes we do worry about going back up on doses unless we're sure that you're going to tolerate well. So.
But what I was telling Dr. Christie, I know I'm beating this dead horse. She bunkers in when she's sick, even not this cancer.
She what?
She just she goes to the bedroom and she does that. So for her to complain that it's about the cancer, it's a normal thing, and how she handles sickness. Period. I've known her for 43 years. So to judge it off of what she didn't have her pain under control for the 8 days.
Yeah, but the diarrhea and the sickness and losing weight, that was
and the nausea. Yes,
yeah, that
I
was
understand
from
that.
the chemo, not just the pain.
I'm just saying, you can't judge it off of everything that she says. It should be.
No, it was in the hospital for 10 days. That's what
8
he's
days.
judging it off from.
Well, I think we know irinotecan is one of those drugs that does cause fatigue and diarrhea. That's pretty significant for patients. Tailoring the dose is important. Finding that sweet spot is important. Right now, I think you're tolerating things well with the dose reduction. So I would leave it for now until we get the opinion of what to do next. And I'm happy to discuss things, but those are 2 known side effects that really impact our treatment for irinotecan. So.
Okay. So the risk of her not being able to get it.
I want you to
And
function
getting
at
out of
home, right?
getting
I don't
out
want
of
you laying in bed all
sequence.
day.
Right.
Well, she's not functioning at home regardless.
Yeah, so I think, we need to think about that, right, too. So do we need further dose reductions, or is it not the chemo that's causing those? I'm happy to discuss those things, But, you're here looking pretty well, I would say. And every time we see you in clinic, you look well.
Yeah.
But that important information you're providing me is important of how you're doing at home.
Right.
And that's what we say performance status, right? So you can have bad days, you can have good days. That's acceptable. But
Right,
we want those good days to outlast the bad days, right?
Yeah.
While you're on treatment.
right.
And this is not an easy regimen you're on. Right? You know this, and we kind of talked about this early on. It's one of those that we reserve for those patients that we think can tolerate well.
Well, I'm not trying to say just give her everything, it's like, I don't care if she's super sick. It's not about that. I just want her the best chance that she can be to shrink this cancer and get it on the run.
Absolutely.
That's all I want.
I agree. And I think we're doing that. We've only reduced the irinotecan because of the early on symptoms she had, and we're happy to talk about that again if we can go up on it or what the potential side effects of that would be. Okay?
That's why I thought just jerk it up a little bit just to see if she could handle a little more.
Yeah.
But that's just my opinion. She's final, but I mean, you guys are. I just want you to know from how she reacts to it. It's not necessarily.
Again, I don't know if 25% change in that dose is making a huge difference in the overall picture, right? I think getting the drugs in on time is helpful,
Yeah.
And then just monitoring your side effects. And so let's see what happens with the surgical opinion, and happy to continue our conversation at that point. Okay.
All right.
Okay,
Thank you.
sounds good.
Take care, guys.
All right, thanks.